Start. Thank you, everyone. Good morning. My name is Timur Yurikov. There's some people that I don't recognize here. So this is my third year since finishing residency. I'm about 430 cases in. Still learning. It was an interesting transition. I always get that question, what was the hardest part of becoming an attending? And you hear all kind of answers, but for me, it was really this part of fusion. Since I specialize in spine surgery, so patients come in my clinic with their back problems, and they expect me to fix them and make them better. And here I am from training, coming out and not really understanding what does fusion do. And of course, I don't mean in a way where I have no idea what fusion is and how to do it, but really, there's no long-term follow-up that I have in my head that I've seen and experienced. You can read about it, but still, it's not the same when you talk to the patients and when you tell them, or when you give them some kind of information about their future, what may or may not happen. And if you offer them a fusion surgery, what outcomes to expect, you can't just tell them, oh, you're going to be better. It's a bumpy road, as it turns out, right? And so in clinic, patients come in and they come at different stages of their back pain history. Not everyone gets a surgery or needs a surgery. And then so now these days, most of the time in my clinic, pretty much I am the concierge to rehab and pain doctors. All I do is just give those prescriptions, refer. And that makes me feel weird too. I'm spending the whole day and all I'm doing, I'm just like a secretary to these guys, redirecting patients to them. At the end of the day, I feel sometimes, am I missing somebody? Maybe there is somebody I can help. So, and I wonder if it's just me, and everyone else is much smarter. And if you guys have no problem with that, I would love to learn from you. And maybe I see Dr. Vanny, Dr. Green are here, senior spine surgeons as well. Would love for you guys to chime in and tell me how you approach that too. I'm going through my board's preparation right now. I submitted my case log and it was flagged by the board as I had too many fusions. I reviewed my cases with 125 that I submitted, 18 were lumbar fusions. So maybe proportionally that's a little higher than what the average log looks, but I figured with my spine only practice, probably not that bad. Anyways, I had a meeting with the board. We reviewed the cases and then they unanimously decided that it was all fine. It was just flagged for no reason, I guess. So big question, right? What is fusion? And spine surgery 2021, there's really two things that we can offer when patients come in, and it's a combination of either decompression or instrumentation. There's no other actions that we can perform in surgery. It's not as cool as cranial, right? Where you can do bypass, tumor resection, and all other cool stuff. Repeat shunt. Spine is simple, two actions. What can we remove and what can we fuse? And pretty much all of the surgical plans comes to that. But of course, if it were that simple, I could end my presentation on this slide, right? And not even go further. But I wish that were true. We could do our spine fellowships over Zoom, just show them the slide and say you're good, go into the world and fix people. This is the absolutely perfect case that when you book them for fusion, you feel good about, and they'll do well. Who we have here? Vignesh, can you hear me?
Yep, I can hear you.
Hey, thanks for being there.
Yep.
Come up with a story based on these images for me.
So based on the bone quality, I'm guessing this is probably a young patient with a pars defect at L4. And as a result, she looks like she has, my guess would be on the right side, the x-rays of her standing up. So my guess is that he or she likely has dynamic instability with anterolisthesis of L4 and L5 that you can also see on the MRI on the left hand.
And what are they complaining of? So they come to your clinic at some point because they already, I guess, had accumulation of symptoms, making them go and seek the medical opinion.
My guess is that they likely have back pain. They're coming in with presenting complaint of back pain that's worse with movement.
Okay, exactly, right? So two things actually what people can complain of in the spine clinic: back pain or some kind of a weakness, right? Neurologic compromise. So, and then usually with the with this type of presentations, when you have pars defect, Mobile listhesis, that's kind of significant grade. Patients come in with this breakthrough weakness. No, they can say they're walking and all of a sudden their knee buckles, so they just lose strength and they fall on one side. Or going up and down the stairs, they're afraid because they've tumbled already a couple of times. So it's that dynamic compression of the axillary nerve root. And so those kind of stories, and then of course, before you do any surgery, we always talk about conservative measures, which I'm going to cover here. But when you get to the point of surgery, once you fix that, once you stabilize that, patients do well. So far, anyone that has come in with this type of pathology and that I had operated, I have very good feedback and it just works out well so far. Okay, not talking about the long-term effects of fusion surgery, but at least in the short term, people are happy and it's a very satisfying case to do, and doctor-patient interaction. But these cases are maybe 1 in 100 that come through the clinic. What do you do with the other 99 people that have back pain and then want you to fix them, right? So for instance here, Mike Silva, you're there?
Yeah, I'm here.
Thank you. So, a 35-year-old guy comes in and says, hey, I have a lot of back pain. Help me, doctor. And, they show you the MRI. What do you tell him?
No, there radiographically, I don't see any significant central stenosis. I'd ask more about the quality of this pain, any provoking factors, if there's any radiculopathy. But based on these couple of slices, I don't see anything significant.
Mm-hmm. And so they come in and say, I'm severely debilitated. Every time I play soccer, I can't play the whole, 2 times as I used to, right? But in the middle of the second half, I have to get off the field, and it's annoying. I'm used to playing the whole game, and it's embarrassing. Doctor, help me, right? So they're very vocal, right? And they come in and the spine looks like this, and you're looking at, okay, I don't really see anything that's surgical. There's no frank instability that you can see from this, supine, of course, static MRI. There's no compression. But do you see anything positively at all? Is this a perfect spine?
I mean, it looks pretty good. Maybe some very mild degenerative changes, but I maybe would want to see some flexion extension imaging, some standing X-rays, and go from there.
Exactly. So, no MRI is perfect. You can always find something, and you'll see why I say that. But in general, there's a well-known fact that the lower back pain is one of the top reasons, why people miss work. And there are these estimates of $90 billion a year in the US is not made because of the back pain, and then all the additional expenditures. And, all these numbers, of course, I didn't fact check, so I just quote the internet for that. But the fact is, I guess the idea is that the numbers are vast and huge, and it's a real issue. And it's not just US, it's worldwide, right? So imagine you come up with a solution to get rid of this back pain or make people better. This is a Nobel Prize worthy invention, right? And is the fusion the answer? As of now, that's the only kind of answer that we can offer. And we don't offer it, of course, to everybody. And so you end up with 99% of patients with back pain not getting any intervention and relying on their own ability to rehabilitate themselves. So this is what I learned in my clinic setting. They come in there and their insurance is billed $400 to $600 per visit. So when they come in and they have a back pain, and you just come up to them in the clinic office and say, hey, there's nothing wrong with you. Thanks for coming. Good luck, right? They hate it. They write bad reviews. They live disgruntled. They go see someone else. And then, as you guys know, community, you see 10 spine surgeons, you'll find someone to operate on you, right? And that may initiate the cascade of all of the post-operative complications that should never have happened. So instead, these patients, then there's a lot of them. It's usually these young adults, professionals that had a slight change in their functional status from a full 100% that they're used to from their youthful years to maybe 95%. And to them, it feels like an end of the world. They feel like something must be done, and there must be a quick procedure to fix them. Especially the type A personalities, the go-getters, like, I can't wait. We got to fix it. Can you fix it? And so just telling them there's nothing wrong with you, it's all in your head. right? That's what they'll feel. They're being called crazy. They don't like that. Instead, usually I've learned that to spend actually a couple more extra minutes with them and explain that, yeah, maybe they're undergoing early degenerative changes. There could be some fissuring at the disc, and you can see the slight bulges along the lower lumbar area. You can see some darkening along the disc spaces, all indicated there could be some strain and maybe early inflammation that could cause the back pain. So by acknowledging their pain, they already feel more calm. They feel like, okay, there is a problem that we can address, and then we can talk about all the conservative measures and all the things they can do. The goal is always kind of try to steer them away from surgery so they don't keep thinking about that, okay, there's surgery is the ultimate answer, and they keep looking for it. Dr. Manu, do you agree with that? All right. Still brushing teeth.
No, I do. There's always multiple options to give them.
Right, exactly. And I'm gonna, we're gonna talk about all of this. And today's talk is not gonna be, about surgery, right? How we can do it, what techniques we're gonna use. This is more of that step of, seeing 100 patients in clinic and kind of triggering which one of these patients should I offer a fusion to. So, and it was the biggest, again, like I said, transition to me in knowing when to pull that trigger. And I'm still in the process of figuring it out. It's kind of a trial and error. You come up with a small theory of what works the best, and then you test it, and then you see if it doesn't work, alter, the approach. And I'm still in the process of that alterations. I'm not settled 100% in my ways of fully understanding what will a fusion offer.
No, I agree 100%. I also tell patients you can never look at an X-ray, an MRI, or a CT, or any other diagnostic test that gives them a pain scale. Everybody's different. Some people have normal MRIs and they have debilitating pain. Some people, you see it, have the worst MRIs you've ever seen, and they're walking into your clinic and they say there's nothing wrong with them. They're not even sure why they're there. They were sent by their doctor. I mean,
exactly. And especially, everyone reads the radiology report, and radiologists kind of note on every little shade of gray and little bulge, and so they come in all freaked out. They're like, I have herniations.
Agreed. So, great talk. Yep.
Yeah. And so, of course, sources of back pain. Why does back hurt, right? And as we know, there are different structures within the spine itself. The disc can undergo inflammation and fissuring and degeneration. Facets become strained, and they're also well innervated. As a result, you can have a muscular overcompensation where now the paraspinal muscles have to work overtime pretty much in maintaining some sort of a balance. And then you have a muscular pain. Of course, you can have a neurologic compression from all of the above, degenerative changes, facet arthropathy, and the neural roots themselves may be compressed, so you get the pain from that. And of course, never forget that people might just be crazy, it could still be in their head. And so the psychosomatic component should be kind of on the back of everyone's mind before they really commit themselves to that. Yes, the back pain is truly from the spine. And I've met already a couple of patients, and I've operated on patients where I did not consider their mental health, and it backfires. And you end up doing I ended up doing the wrong thing, and patient got worse in terms of their sensation of pain, regardless of how well their spine looks. And of course, people have different occupations, right? And then they would create, from the previous slide that I showed you, the different sources of back pain. When people come in and say I have a back pain, based on what they do, you can kind of predict how the MRI can look. So, Cadbury, I have two pictures here: a guy working in the office and the guy working at the construction site. From the previous slides, what type of pain do you think they'll have most likely?
The guy working in the office probably has upper shoulder pain, neck pain, trapezius, muscular pain. And then the construction worker, I would assume, has low back pain from heavy lifting over years of his life.
Well, you're very observant. If you just concentrate on the lower back pain, let's say, so to make that clear. So the office worker versus the someone who does a lot of manual labor, where do you think their source of deterioration is going to be? The initial kind of insult and injury.
I think one is from postural instability or postural misalignment and not sitting in the correct position, losing your core strength. And then one is from like pure axial loading and stress on the joints.
Exactly. So the construction worker will have most likely the facet joint strain. And of course, this is all very general, right? It's kind of trying to create a spectrum here. It's always a mixture of things. But speaking just in ultimums, the construction worker will have the facet joints, the facetogenic type of a back pain and the muscular strain. And the office worker who's sitting always, and when you sit, the weight, the axial loading is translated to the front anterior column of the spine. So most of the load is on the discs, as opposed to when you're standing and doing manual labor, most of the load is on the facet joint. Of course, again, in the construction, it's a little different, but there are those two differentiations. And a lot of people actually feel better with the discogenic type of pain. They feel better when they stand up, when they change the load onto the posterior column of the spine. And people that have more of a telogenic pain, they actually feel better when they bend forward, slouch forward and relax the posterior and lean more into the front. And so now you have two different sources of pain, and how do you treat that, right? In terms of conservative measures, do you just tell them, oh, do the same thing, core strengthening? Who would benefit from the injections? That's what I kind of try to think about. And the conservative measures, there's a whole bunch that you can just say, go do this, right? Christian, I see you there too. Can I tag you in?
Yeah, what's up?
Okay, good morning. When you think of back pain, and let's say you're a doctor, right? You're a neurosurgeon, so you have a lot of friends on the outside saying, "Hey, this hurts, that hurts." What are you talking to them about? What kind of activities do you tell them to do?
Well, I usually when I have people ask me that kind of stuff, I'll usually try and figure out what kind of back pain they're having, and most of the time it'll be like paraxial, muscular type back pain, and I'll tell them to stretch. I'll tell them to do core strengthening exercises, range of motion exercises, things like that. Just because that's mostly what people, friends or random people, will come up to me and ask about.
Exactly. So I feel the goal of conservative management should be, always stretch out and strengthen, right? And it should be an active process. A lot of times patients come in the clinic and say, "Hey, I've had a physical therapy already, but nothing helped me. Let's do the surgery." And then you start asking about what exactly did they do, and they're like, "Oh yeah, they did the massage. I did the chiropractor. We did a couple of sessions of inversion table and traction." And my back pain is still there. And then I say, "Well, what do you do for your core strengthening?" And they go, "What is that? What kind of exercise you do? What can you do?" And a lot of times they'll tell you they haven't really done anything active. So in that list of conservative management strategies, I always feel like there's a passive way and an active way, right? So anything that can be done to the patient is a passive way of relieving the pain, whether it's an injection, a massage, acupuncture. It helps relieve the pain, but it doesn't really change anything structurally. So if you don't really strengthen your own body, you haven't really done the therapy. And so when patients come in and tell me, "Yeah, I've done therapy," or they say, I've gone to the physical therapy 12 times already. So they've gone 12 days, did some workouts, and they're not feeling better. Is that sufficient enough? These guys, let's say middle-aged, 45-year-old gentleman, construction worker who's being overloading his back for 20 years with 80-pound cement bags, and now all of a sudden you want to reverse his pathology in 12 visits. I just don't think it works that way, right? You should be more patient. You should give it more time. And the way the medicine is, now insurance authorizations, right? They would say, "Has the patient done 6 weeks of physical therapy?" They have to give you some kind of, I guess, number, but is even 6 weeks enough? I mean, can you just say, "Yeah, they've done therapy," and then sign them up for surgery just because that's who insurance is? I think it's still on us to make that decision, what is appropriate in terms of physical therapy. And if they need longer, you give them longer. And if you can see that patients are lazy, they don't want to put any work in, then you kind of feel, okay, if you don't want to put any work in, why, how can we have this relationship where I can trust you, right? With the recovery after a complex surgery. And also the sources of the pain. Here I've put a picture of an AP X-ray, just to see Mike Hader. Can I tag you in?
Yeah.
Thank you. Can you describe the X-ray?
So it's a AP X-ray. He's got some scoliosis, coronal deformity. You can see worse degenerative changes at like L2, 3, 4. So he's probably has some. I guess I would say his back pain is probably worse on the left if he's having any radicular symptoms.
Exactly. So you've noted the scoliosis, right? And I'll tell you, this is a let's say 35-year-old person, works in the professional world, has back pain, no radiculopathy yet. What do you tell him?
Obviously, I mean, it depends on what kind of conservative measures has he tried.
Hasn't really done anything.
Hasn't done anything. I mean, probably physical therapy, like you said, core strengthening exercises to sort of help maintain the stability of his spine so it's not as mobile as he's walking around or doing anything. Could probably help with his scoliosis.
What do you think the source of his scoliosis is?
If since he's young, I would probably say more likely to be congenital versus acquired over the course of years.
Spine is a mechanical element, right? So it's a combination of structure, forces, gravity, and time. So when I see a curve like this, and I actually learned this from being fortunate enough to be next to Dr. Vanny's clinic, so we get to talk about things all the time. So when I see a curve like this, I always think, okay, what's the underlying condition? Why are they having the curve? And the curve is usually either, of course, we don't see young patients where you have that idiopathic juvenile scoliosis, which is related to a musculoskeletal imbalance, right? Parts, something's weaker, something's underdeveloped. But in the more of an adult population, the curve is, to me, in my mind, a lot of times is the reactive, a compensatory curve to some underlying issue, whether they're alleviating a pain on one side and they're leaning away, or on this X-ray, you see I drew the lines across the iliac crest and acetabula, and you can see how they're at different heights. And that's the point I'm trying to make, that just, visualizing this and checking whether their base is even or not could indicate that maybe they have a leg length discrepancy, and that could be especially catching in an earlier population, giving them information, telling, listen, your right leg is shorter, so maybe for the rest of your life, you should consider wearing a slight lift in your shoe so that the spine does not feel or does not have to overcompensate and bend the other way to maintain that balance. I think this is a highly under-recognized factor and issue, and that's actually what Waverly Rose is working on right now. And I have some medical students that we're trying to come up with a way of putting this, into a package and show it to the world as this is a really important factor to look. And so far, we see that it's highly under-recognized. If you look at these X-rays, radiologists don't know that. They don't tell you that, the pelvis on the AP X-ray is tilted. And if radiologists don't know that, a lot of physicians that read the radiology report will not make that include in their assessment. Of course, by the time they get to spine surgery, it's usually too late. The spine has been compensating for many years and has accumulated that advanced degeneration because of these extra added forces of rotational scoliosis that pretty much grinds out the disc a lot faster. So I think that's if anyone's interested, you guys are welcome to jump on the project. I think it has a higher impact if we're able to educate either pediatric doctors or primary care doctors to recognize that, and hopefully maybe we don't even know if that truly is the cause, but if shoe lift would work, but maybe, and it's more of a long-term benefit to the patient to be able to stabilize their pelvis and therefore their spine. Any comments on that from the senior faculty, Dr. Cote, Dr. Vanny?
Well, yeah, I'm impressed. Yes, the actual X-ray. That's why in my clinic everybody gets an AP pelvic X-ray. right? I make sure on my protocol, you always include the acetabulum because it's quite, it's missed quite frequently. One of the first patients I ever saw, his back pain wasn't from his back. He was actually scheduled for a lumbar fusion, and the guy had osteosarcoma of his hip. So I think these points are very important. And sagittal balance and back problems don't even begin in the pelvis. I mean, that's why these newer X-rays, you see them you look at their feet, you know. And I think, you know, a lot of doctors do look at this stuff. Unfortunately, as surgeons, we ultra focus, especially spine surgeons, on the back. And I think that these are great topics. And these type of patients present with sciatic pain from a piriformis syndrome from this type of discrepancy. And by giving them the lift, a lot of times their sciatic pain disappears and their back pain may disappear. But these are all great valid points. Very impressed.
And
Thanks.
I would add, Timber, I would add also that those x-rays are only valid if they're standing. So you don't, unless you order the film, you don't know if someone's done a supine lumbar, you know, AP and lateral versus a standing. And it's very important that they stand without their shoes on, flat to the floor. And I believe not just a lumbar and pelvic, as Dr. Vanny said, but I order scoliosis x-rays on all patients with back and neck pain so I can get a better perspective of the entire skeleton and the balance on multiple planes and multiple factors.
Exactly. Thank you so much. And of course, the older the patient is, the more in pain they are. They accumulate hip problems, knee problems, and a lot of times it's not even the leg length discrepancy, and you can't even fix it with the shoelace because they're compensating for their limb issues, and they're avoiding certain weight bearing, and that's why it may look even crooked like that. So there are many factors to consider, but I think the general kind of approach to looking at this is very important. All right, so you have this pain, you have this patient right now, right? That you've seen 6 weeks, 8 weeks ago. He said, yeah, I have a lot of pain. You tell them, go do physical therapy. They come back after 6 weeks and say, listen, I'm still in a lot of pain. This is, you know, I read my MRI. All of my discs are herniating. We have to do the surgery. And, you know, and this is the MRI that you see. This is kind of the next stage of the progression in the spine degeneration, right? So I see Sumedh logged in. Sumedh, can I tag you?
Of course, yep.
Can you tell us what you see on these MRIs? I know they're two separate patients, but they kind of show a similar picture.
Yeah, on the MRI, these are sagittal MRI T2 weighted that are showing, you know, you can see the disc spaces in the left image, 4-5 and 5S1. They're seeming to be like desiccated in comparison to the ones above. Meaning that the white where like the nucleus pulposus would be is starting to degenerate.
Exactly. So you know, we hear this term a lot, right? Black disc, dehydrated disc, dark disc, and now we're starting getting to a realm. Okay, patients have real source of back pain. They are uncomfortable. Should you fuse them? I mean, that's a big question, right? As a surgeon, they come in and they say, I'm in pain, help me. Do you fuse them? And how do you approach that? And I, you know, I didn't see Dr. Heroes here. I kind of made this slide, the title, to tickle him a little bit, but I don't think he's here. I remember him giving a few grand rounds of talking about back pain. He'd always make fun of kind of just the general approach that everyone should be pain-free. It's everyone's right to be pain-free, and whether or not that's true, of course. And you know, I say it's not true. It doesn't mean that if patients come in and they have back pain, that it is your absolute, you know, priority to get them pain-free completely. They'll probably never be pain-free, and I think that's something we have to realize. Earlier on, and still, sometimes people come in and I feel like I must help them, right? I'm a spine surgeon. I'm trained. That's what I do. And people have back pain. I must help them. That's not true. I learned that the hard way. There's some pains that you cannot help, you'll make them worse, right? And so this is kind of a continuing along the paradigm of degenerative disc disease, right? Continued progression of disease. back pain, and how do you approach that? There's that one insert from the paper from 2002, Black Disc Disease commentary, and they talk about approaching these, how you wait for 6 months, physical therapy, not relieved, and considerable discomfort. Then they talk about fusion and saying that fusion helps them. It's. I hope no one just reads those papers and say, "Oh yeah, fusion helps black disc, so let's just fuse everybody after they're gone and do some therapy." In general, this is when I think of a spine surgery, because if you think about it, pathologies are different, people are different, and the surgical approaches can be different. So, but in my mind, I try to conceptualize it in the easily understandable packet of information, right? How can I kind of overview it so I don't get lost in all of this? So this is just one of the concepts that I keep in my mind. The same MRIs you saw before, patients in back pain. And there's this imaginary line, this red line, that if you commit them to surgery, they will never be better than that line, no matter what you do. I mean, this is, you can prove me wrong, but your 25-year-old self, when you feel 100%, your back is, is made of full steel with full flexibility and full ability. If you take that as your 100%, and then anywhere along your lifetime, if you get a back surgery for any duration, you'll never get to that 100%, no matter what you do. And so people come in, especially like I was mentioning earlier, younger people, type A personalities, that feel they have dropped from 100 to 95 percentile of overall their, capacity, and they feel debilitated. They can't do their normal activities. They can't complete a full marathon. They can only do half marathon. If they do a spinning class right after their Pilates, they feel their back pain is worse. And so in their mind, they're panicking, right? They're aging, they're getting old, and they feel like, I got to do something. And sometimes it can come in and be very convincing in terms of how much they're hurting and how much they need help, and that they've tried everything. They're active. You tell them do physical therapy, and they go, listen, I can run for 2 miles. I don't need physical therapy, but I have back pain. Help me. But I feel keeping this graph in mind kind of allows me to stay on track in my conversation with them and not be convinced by anyone that okay, let's do fusion. It sounds like you're really debilitated. If they're anywhere along above that line, let's say, and of course the line currently drawn very optimistically at a 70 percentile or something, I'm sure the surgery is much even lower. It doesn't get the numbers are not true, but just for a qualitative assessment, when they're above that line in their condition, no matter how bad they feel, and if you do the surgery, they will feel worse. And those are the people that say, oh, I should never have had that surgery, or spine surgery not help me, or it made me worse. I feel that's why, when you pull that trigger and you offer them fusion too early, no matter how debilitated they are, they will only feel worse, because there's no way of getting above that line. Of course, when patients come in and they are truly debilitated, and you can see that, and you feel that you can help them, they may feel some improvement. They'll never get back to the 100% again, but there's that gain of ability. This is highly subjective, right? I mean, this is where the art of spine surgery comes in. How do you determine that in your mind? I have no answer for you. Maybe someone above has, more points, but for now, at least I think of this way, and I feel if I see a patient, I try to think, are you still above that line, or can I really help you? And that's an active thought process. There's no true recommendations from me right now for you guys. All right, so now patients come in, with symptoms, pain, neurological deficits, combination, right? And then you see all kinds of MRIs. Let's say they have back pain only, then you're stuck with looking at their images. And there could be different signs, different findings on the images that you look for. How do you interpret that? As I mentioned, the grade 2 spondylolisthesis with pars fracture is a beautiful finding that correlates to the clinical picture, and you feel, okay, I can help you. But like I said, 99% of people will have a mixed picture, and then you think, okay, what should we do? So for instance, the MRIs here, it's the same person, just in the middle is the midline, and then you have left and right parasagittal views showing the foraminal openings. You have an ongoing degenerative disc disease, and you can see the blue and red arrow. See how I can ask here. Damien, what's the difference between those foramen?
You said Damien, right?
Damien Brusco, yeah.
I mean, the foramen there, like 5, 4, 3, 4 looks more narrow than at 4. You can see the CSF plane all around the nerve right there at 4.
Mm-hmm. Let's say I told you both of these nerves present with radiculopathy. Patients have, pain going down the thigh, groin, kind of, in the general 3 and 4 areas. So the nerves are being compromised, but think of a mechanism. What's causing their compression?
Looks like at 4, the red arrow there, there's more facet hypertrophy, like there's more kind of compression of the hypointense material posteriorly versus at 3, at the blue arrow. You can still see some like ligament there.
And the disc, right? You can see how the disc is protruding more. Yeah. Right, exactly. So there are different sources of these pyramidal compression, right? We have an ongoing degenerative disc disease with height loss. And that, I feel that's what creates a lot of the problems, right? Chicken or the egg, is it the facets or the discs? I feel the majority of patients really undergoing the degenerative disc disease with loss of volume. As a result, their segments settle and the excess soft tissue buckles in. Just like you have a 3-4, you have a disc protrusion. It's not real herniation. I feel like it's just the excess original collagenous tissue that used to be spread open and stretched, now compressed. At 4-5, the discs are a little, it's bulging, but it's not as close to the nerve root, and it's more of the superior articulating process now impinging into the foraminal opening, again, from the same height loss, right? So 2 different mechanisms. So let's say for the strictly L4 radiculopathy, you can think how can we help that? And that's where all those decompressive procedures can come into effect. Maybe even endoscopic surgery where you can shave off the SAP. Same thing for 3-4. Would that work? Maybe less likely because now you already have the disc bulge impinging into the foramen, and you can do foraminotomy, but then the ongoing disease will progress, and then you're back to square one. So those are the things that you kind of look and think, all right, so patients coming with back pain, radiculopathy, degenerative disc disease, can we just do a decompression? Or do we need to restore the height of the disc space? Unfortunately, the only way to restore the height these days is with placing an interbody cage. Of course, we can talk about Coflex, which Dr. Vanny likes a lot, and that's a different discussion, but there should be a mechanism, right, that we employ where the space opens up, and that's the indirect decompression. I just put one paper here, but there's multiple papers that evaluate the cross-sectional area of the foramen before and after interbody fusion, lateral fusion. There's different type of papers on that. But indirect decompression, I guess, has been shown as valid. It works. Are we doing too much by adding an interbody and fusing that segment? That's a question that still needs to be answered. Or is there something that we should concentrate our research on to help the disc regain the height without doing the fusion? I mean, I think that would be more valuable. And unfortunately, we don't talk about that. If everyone's right now at the Spine Summit in San Diego, and I looked at the program, and as always, the list of topics is about how we do instrumentation fusion, how well we do with fusion, not a single topic of how we can prevent the fusion or if there's anything else that we can do to avoid the fusion. So that's a little sad for 2021. Next, radiographic findings, end plate edema, modic changes. How correlative are they to patients' back pain? And what are they? So let's see. We can tag in here. Roberto, are you there?
Yeah.
What do these end plate changes tell you?
I mean, they basically tell you there's a active inflammatory process ongoing at those bony end plates. But there's something going on at that level, I guess, in a basic way.
Do you know the differences in the types of changes? Like this, the modic changes have been described now for 30 years, the type 1, 2, 3. Do you know anything about that?
Well, I guess I know the simple I guess classification where
you start with some subtle changes in the end plates, and then at the end you can have severe inflammatory changes with decrease in disc height. I guess that's I think all I know.
Okay. All right. So like I said, Modig described this 30 years ago, I guess, 3 different stages, and they pretty much, as you can see on the right image, how they progress from just being the T2 signal, which means, the active inflammation, the water signal, right? And then there's a fatty stage, type 2, where now your marrow is infiltrating and the T1 signal becomes high. And then the last stage of just fibrosis and hardening of the end plates. About, I guess, in 2000, it seems in PubMed there was kind of a surge of papers looking at end plates and what they do and what they cause and how they correlate, whether or not treating patients based on their end plate changes, Modig changes, help them with their back pain. People looked at fusion rates. Still very inconclusive, and I see their papers talking about it helps, it doesn't help to look at the end plate changes. What they did find of true positive correlation, that patient that had a patient with type 3 Modig changes having an interbody fusion has a higher chance of non-fusion. So it seems that they would create pseudoarthrosis, or the fusion is not complete. Maybe it's related to a nutrients delivery, with the sclerosis of the end plates, pretty much no access to the disc space to really develop the fusion mass. Who knows? But they noticed that the higher degree is associated with higher chance of pseudoarthrosis. But also there are papers saying that the higher degree, the rate of subsidence is less. So kind of it's logical, right? You have sclerosis, hardening of the end plates, the density of the end plates increases, so they're not as likely to compress over the interbody cage. Still, there's research now, I guess, on PubMed, again, in these papers that are looking at end plate changes. To me, just kind of conceptualize it, it seems from reading all these reviews and how people try to explain that, the process begins at the disc. There is a local inflammation within the disc space. The annulus of the disc seems to be very well innervated, and that's what creates a lot of discogenic pain. And then there are all these inflammatory markers that probably draw the inflammation force, which pretty much travels through the vertebral bodies, through the marrow, towards the disc, and that's what you start seeing at the type 1. Chronic inflammation creates the type 2 type of changes, where you have fat deposition of some sort, and eventually sclerosis from all of that related to chronic inflammation. How that ties in with the back pain, when to treat it, I can't tell you, but it's just something to keep in mind. So far, I've noticed in my patients, I've never even looked at the different types, but if I saw the end plate changes, very often when they're stabilized, they do feel better. The feedback that I've received, my own anecdotal experience, is that patients with the end plate inflammation improve in terms of their back pain when you put a spacer in there and stabilize them. The vacuum disc phenomena, right? Is it something that needs to be fused? And the vacuum disc implies that there is no more cartilage between the bone. And of course, in this picture, it's a ultimate end stage, complete severe degeneration even of the end plate cartilage. But usually you see vacuum just from nucleus pulposum disappearing. Vacuum always, to me at least, means motion. So the segment must be mobile to create vacuum, right? It's an accumulation, they say, of nitrogen gas, and there should be a negative force for that gas to stay there. True for lumbar spine tissue on the left, and also true when you evaluate fusion, right? And if you see vacuum within the construct of interbody, it tells me that there's pseudoarthrosis. But is it something that needs to be fused? That's a question. There are, of course, different opinions. Here's a survey from 2020, which is fairly recent. So just a survey to a whole bunch of surgeons saying, how do you treat vacuum? Do you treat that? To me, it says that there's no consensus still, in our time. We still don't know whether or not we truly should treat it. It becomes a matter of, own opinion and own judgment. Here's an example at the VA. You get to see the extremes of spines. It's completely different and interesting population of patients. They don't like most of them going to see a doctor, or there's an extreme, of course. It's a spectrum. Some of them come for the littlest things because they have secondary gains. And there's a lot that just avoid coming at all. Like this patient right here, he's had this vacuum signs prior, and then he comes back and says, back pain's a little bit better, still a little bit. So, it's kind of all promising, right? It tells you, it makes me rethink, should we really react to vacuum every time? And also when I see two vertebral bodies already touching each other, meaning the disc is completely degenerated, but they have no radiculopathy related from the foraminal compression. Somehow they got lucky. Maybe they had generous foraminal opening from the beginning. If they have no radiculopathy, I doubt they'll ever develop any neurologic compromise from that degenerative disc disease where the bones are touching. They may have back pain, but usually it seems that people can tolerate back pain, especially at the older chronic stages, whether it's a sensitivity across the disc space, that neurological signal that comes to the brain telling you about pain. In the more chronic stages, people are much happier with just the back pain. It's only when the nerve roots are starting getting compressed and their legs don't work, that's what bothers them. So that level will never get compressed any further. The bones are already touching, the end plates are hard, it's not going anywhere. Of course, facet space enlargement, another finding that you see on the images. Not going to tag anyone here, but just look at the images. Let's start with the right-sided MRI. On the axials, you see an enlarged space between the facet joints, that extra T2 signal showing that there is space between the superior and inferior articulating processes. And that's a potential space for motion, right? You can see on the CAT scan an enlarged gap between within the joint. And then the X-ray confirms that there is an active motion with standing and moving. And again, the symptomatology can be various. Patient can just have back pain, or patients present already with, in this particular case, L4, maybe even L5, radiculopathy, weakness, and that of course becomes a consideration. At what point do you fuse? But that's just another finding that could be present, and I think sometimes it's missed. Even if you look at the MRI only and you get in the mid-sagittal view and you see everything's open, the canal is open, you may miss the enlarged facet joint if you have no other images like CAT scan or X-ray to tell you that there may be instability. Something to look for. And of course, you can get a combination here. There's a vacuum disc and the facet disc degeneration. And this patient would present with, this is a real patient. He's a 55-year-old bolt mechanic with symptoms more correlating to an L4 radiculopathy. Nothing below the knee, nothing in the L5S1 distribution. It is all L4, kind of reinforcing that concept that L5S1 are pretty much already bone on bone. He hasn't developed any radiculopathy related to that, and I doubt he will ever get it, unless of course he fractures something. But it is the L4-5 that is causing his issues, and maybe concentrating on that level alone and not just treating the radiographic images is what he needs. So after all of this, when to fuse, right? I still don't have the proper answer, but I tried to conceptualize it. I tried to use these pieces of information that I showed you and kind of keeping in my mind. Of course, when you have a neurologic compromise, like an L4 nerve root being compressed by the dynamic instability, and just doing the decompression, it's not going to help the instability. That's kind of a clear indication. But then everything else, 2, 3, and 4 becomes highly subjective. And pretty much every underlined word, failed reasonable conservative measures, back pain causing significant reduction in quality of life. Surgery risks do not outweigh the potential for improvement in quality of life. All those words, they're subjective. And that's where it's the art of spine surgery, right? That's why I guess a lot of surgeons may not even agree. But who knows what's the reasonable conservative measures? Who decides how much quality of life reduction is enough to trigger the surgery? And how do you assess whether or not surgery risks are really high and you shouldn't touch that patient, even if you believe surgery would help them otherwise? I mean, that's what still becomes highly subjective. We talked about this, conservative measures and sending people on that route. And then in contrast, Dr. Alex Ricard, right, the president and CEO of Rothman Group, says that there's some patients that it's not going to work. So why send them that route? Why can't we just take them to surgery right away? And he says there's no value in in talking to insurance companies that say he hasn't done any physical therapy, and you try to tell them it's not going to work. I know exactly why it's not going to work. Let's operate. It's a dangerous thought process. You can't just give everyone a license to say that. You think about it, you can imagine if spine surgeons were free to operate on anyone without and saying conservative measure is not going to help. It's going to create a dangerous world. But in a way, you know, there are situations that do fit that, and there are situations that don't. We got to be somewhere, you know, of course, in the middle with flexibility to think. How do you check for quality of life, right? I mean, there are all kinds of different scores, you know, and here I have a picture of what I've just implemented in my clinic. It's kind of a modified ODI, as Wall Street Disability Index, where I ask the patients about their ability to just have a normal day, you know, how much pain they have, what activities they can do in terms of standing, sitting, lifting, how much social life, you know, quality of life, how much fun they can have, their hobbies. And then by just looking at that image, I can see at what stage they are. You know, the lower they mark, the higher the percentage of disability. So for instance, for this patient, she seems to be hovering around 80%, 80%. Unfortunately, this is my post-op, right? I mean, this is someone who I want to make better. Granted, this is an acute period, and there's that price of surgery that Dr. Wang talks about. But still, this is what I use to at least kind of, in my mind, assess, other than looking at the radiographic images only, hearing their story. You know, this helps me save 10 minutes by not asking these questions directly in clinic, but at least they check them off and I know where they stand. There must be some more objective ways of measuring that. And we always constantly have to think about what's a better way to really assess that quality of life. It's not 100% known right now. And then, of course, when you assess risks of surgery, you know, you looking at the patient in the clinic when they come, they're usually in the balanced state. They come in, they're smiling, they have their back issue, but they're not telling you about all the other problems they have. They're concentrating on the back surgery or back issue with the spine surgeon. And, you know, considering the surgery, what are their risks of developing infection? You know, that's why we do the pre-op clearance, where the older patients may need cardiac clearance with a stress test. We want to know how much capacity, right? How much reserve capacity they have in their systems to tolerate the surgery. And so that list this year is kind of in the temporal profile, you know, from the most acute to chronic. You know, you can have any of the organ failures, you know, heart, lungs, vascular issue. I mean, any of those things can go wrong. And then further on, right after surgery, further on, you can have infection and, of course, hardware failure, right? Subsidence, pseudoarthrosis, adjacent level disease. And, you know, now I'm 2 years out. I've had pretty much every single one of those complications except for pseudoarthrosis and adjacent level disease. And who do we have here? Elliot, I saw you were there. Do you think I do not have any pseudoarthrosis or adjacent level disease because of how great I am of a surgeon? Stephanie, tell me. All right,
Sorry.
no one wants to tell me.
Sorry, I missed
Yeah.
it. What was your question?
So I haven't had any pseudoarthrosis or adjacent level disease. Is it because I'm an awesome surgeon?
Of course. No, it's probably patient selection, part of it.
Well, it's time. You know, I've only
And
been out
time,
for
yeah.
2 years. You know, so these happen later on, and they will happen to everybody. And the point is, no matter what you do, it will happen, right? And that's you have to consider. You have to include that in consideration when you make that surgical plan. In terms of the concept of this reserve capacity, that's how I try to put it in my mind. When I see a patient, instead of trying to think of all the different systems, or at least all the information that I gather, I try to put them on this curve, the cone of reserve that I conceptualize in my own head. Someone like a pediatric patient, it seems, you can do so much to a child and they just bounce back, right? It seems like they have so much reserve within their body. It's you can help them, and you can see a lot of times what kids can come out of, and it's amazing. You just can't get them off that balance. For the most part in the adult world, it's a combination. People come in at some certain balance, and then there's comorbidities, diabetes, hypertension that you have to keep in mind, and you want to know, okay, how much can we push them before they kind of fall off that curve and fall in the fire a bit. Of course, there are patients with more comorbidities, and that's now becoming more and more fragile, and that's older population on blood thinners. So even considering a smaller procedure, it's those patients that you think, what have I done? Why are they having these complications? They were in such a tight reserve kind of a space where pretty much anything, you look at them wrong and they're destabilizing because they were at the maxed out state in their system. And it could be any organ. It doesn't just have to be heart, lungs. Like, my recent complication of a gentleman, middle ages, small procedure, they usually patients go the same day, but his GI system was so maxed out where I guess the post-operative opioids had tipped him over and he developed this crazy gastroparesis, required laparotomy, and he's still healing from that. I mean, has to have to keep that in mind. And of course, there are people that no matter what they come up with in your spine clinic, you cannot touch them, right? You say the minute they go under anesthesia, that's it. It's going to be downhill for them. So it's not worth it. And just to throw this out there, the talks of spine surgery center of excellence. There was a big, I guess, wave of that in 2013, and it seems to be reappearing now. This is a most recent title that the centers of excellence becoming more prominent in spine surgery as well. It is something that insurance companies are trying to push their patients towards. Places that have that designation of being center of excellence, meaning they have a comprehensive approach to pathology, not just surgeons that do surgery. How much it works, and now there are papers coming out comparing outcomes, and they say it might not even matter, but it's something to consider. See, and then on the right I just put a little it's not the complete list of things that you need to have at the center to be designated as the center of excellence, but I'm just throwing this out there. Maybe in the future we should get on top of it, be ahead of the curve, and how we consider that. So in conclusion, we talked about this fusion, when to trigger the, and say, okay, you need the fusion. And what I've demonstrated what I've been looking at, how I consider radiographic data, clinical picture, and still, even though it's a lot of information, I still feel like it's not enough. It still becomes kind of an objective view of, okay, let's do this. Let's hope it works. And we need more data. I mean, before we really can say that the spine surgery is the science, we need more data. Right. Any questions? I know I'm a little bit over.
Great job, Timur. The old saying, when you have a hammer, everything's a nail.
Yeah, right. All right, well, thank you, everyone. Yeah, I really wish this would be more of a, face-to-face interactive atmosphere, and that's actually what I was hoping for, but then it changed. So I'm sure a lot of you missed a lot of the points, but we'll keep talking about it. Have a good day, everyone.
Timur, I couldn't have asked for a better introduction. The last part of your talk, the tension between, experience as a doctor, experience as a surgeon, complex decision-making, taking all these things into account, and then the need for data, right? And the use of things like standardized, instruments to measure disability, and how both of those things are so important in medicine. And sometimes there can be tension between the two of them. I've wanted to give this talk for years about quality metrics in neurosurgery. And quality metrics, I changed the title of my talk a little bit because I didn't want to get anyone nervous that I was going to talk about other performance metrics, like metrics of how much work we're doing or how much we bill. I thought that's a whole separate subject. But quality metrics or quality measures that are defined, the granddaddy of all organizations, and we'll talk more about this, that uses these is the Health and Human Services Department, the Center for Medicare and Medicaid Services. They say these are standards for measuring the performance of healthcare providers to care for patients and populations. And that's on their website, but the word that they're missing is simple standards. These are not, like Timur's talking about, a doctor's complex understanding of all the things that go into providing good care for our patients. These have to be simple measures. And I got interested in this years ago, and I've wanted to give this talk for a while. I was at one of our VA surgical services meetings, and there was this announcement that VA administration in Washington, right, which is kind of a big deal, had said that there's a new quality metric that's going to be measured. And it's that all patients referred to a specialty clinic like neurosurgery have to be seen within 14 days. And, you know, our leadership said this is a big deal. This is being monitored in Washington, which if you're at the VA is a big deal. And, you know, I raised the question, well, the reason why often we don't see patients within 14 days is they're referred to us without a spine MRI, for example. You know, we need to get these scans done. And the answer was, and I quote, "This is simple. That's a characteristic of metric. Just see the patient, and then you can always order the scans." And, you know, I said, well, you know, patients are going to get angry. It means extra clinic visits. It's kind of inefficient. But, you know, this was the quality metric. And in the end, we found some workarounds, and we don't actually have to do that. And I asked, is this really a quality measure, or is it actually the reverse of quality patient care? So what I do whenever I get upset about this stuff is I go across the hall and I knock on my friend Ken Nissom's door. Ken is an ENT surgeon and very, very knowledgeable about organized medicine. And he's on all the VA committees. And he said, "Ron," he said, "go on Amazon and get this book." So I read this a few years ago. It's a book written for a lay business audience called The Tyranny of Metrics. And the idea is that it can actually be, it's very commonly done in our society and in our professional institutions, but it also has a bunch of dangers to make complex decision-making dependent on the measurement of very simple metrics or simple outcome measures. And it's a great book. It's very entertaining. Don't be fooled by the benign appearance of the author in his publicity picture. He's a conservative professor of history at Catholic University in DC. And he's a very, what's the word, iconoclastic and very entertaining writer. So if anyone wants the book, just ask me, I'll lend it to you. And some of what I present is going to be from the book, but a lot of it is specific for our field. So Professor Muller had asked, well, why, you know, where did this need for simple measures of quality and performance come from? And it comes from the need by society to ensure that our institutions are providing good quality services. And, you know, here's the imaginary school of Athens, you know, back in the good old days, the great organizations of professionals, you know, these wise philosophers and scientists, I think Hippocrates is in there somewhere, you know, would gather and with their wisdom and benevolence would always make the right decisions, and they would police themselves. If you were a crank, like this guy on the stairs, Diogenes, the original cynic, you probably just would be kicked out of the group. Of course, that's not how institutions work. And from antiquity, governments, military, professional guilds and organizations have always, you know, provided substandard services. So after the scientific revolution in the mid-19th century, social scientists and psychologists, inspired by the success of quantitative science, tried to apply quantification and statistical techniques in fields outside of the sciences. So education, factories, you know, education, for those of us who, you know, our kids in school, we worry each year about the standardized tests. The first payment to public schools based on the results of standardized tests was actually in England in the 1850s. This is not new. You know, the time method guys with their stopwatches in factories in the early 20th century, government, the military, and also medicine, easy to measure and easy to process statistically, metrics have become ubiquitous, right, in our society. So how did they become important in medicine? And, you know, Professor Muller, other historians have said that this has been mainly a phenomenon since the Second World War. You know, one factor is loss of trust in organized medicine. You know, in the post-Pentagon Papers and Vietnam era, the public and our leaders, you know, started to lose their admiration and trust for our big institutions. One of those is organized medicine. I know I'm late to the game. I finally listened to the Dr. Death podcast, and you know, of course, the most shocking thing about it is that there was a doctor, you know, in the contemporary era, who was allowed to either kill or paralyze 30 some odd consecutive patients before the medical board took action. So there may be reasons why, metrics of doctor performance or hospital performance that can be easily interpreted in public, why there's a big demand for them. Another big factor is the consumer culture. So after the Second World War, the combination of affluence and increased access to education and information, for example, by the Consumer Reports magazine, meant that we have this expectation now that people make decisions about where they want to, here in this case, which of the 37 brands of cigarettes they want to buy, but also what hospital they want to go to, or what doctor they want to clip their aneurysm or fuse their spine. And in order to make those decisions, they have to have information, and they can't know as much as we do about neurosurgery, so they need metrics. They need simple and easy to understand outcome measures. A number of people have put up this slide or a similar one, at Grand Rounds, accountability for the huge amount of money that's spent on medicine. This is the proportion of our gross domestic product, a huge number, that the federal government spends on healthcare dollars, and we see the number, or I should say the proportion, going up decade by decade as we doctors do more and more effective and expensive things, and as the population ages. So in 2020, it's 5% of the gross domestic product. If you add on private dollars, that consumers or companies spend, it's more like 15%. So the public and our policymakers say, if we're going to spend that much money on medicine has to let us know that they're doing a good job. The availability of computers means that big data can be collected and crunched and processed, where that wasn't possible 50 years ago. And I would add, and I'll show you some examples of this, one of the reasons why these simple quality metrics have become so important is that they're really effective for certain things like research and quality improvement. Whether they should be used for other things is something we'll discuss. So as I said, the definition of a quality metric is that it's simple. It's not, a complex analysis of how good care or bad care we provided to a patient. The power of these quality metrics is that they're simple. So some examples: 30-day mortality, you're either alive or dead. The visual analog scale of pain, it's a simple integer number that patients report. One that we click a box on several times each week in clinic is whether or not we provided smoking cessation materials to patients. I'll return to this, but that's actually a federal government quality measure, and we are paid or not paid according to our compliance with that measure. The simplicity makes it easy to collect the data, and it makes it easy to archive and analyze huge amounts of data. And this is really useful for clinical research and quality improvement. Like I said, I'll give you some examples of that. The other power of simplicity is that it allows, it's a buzzword, transparency, which is that even if you're not a neurosurgeon, even if you're not a public health expert, you can, in theory at least, you can understand and compare outcomes among different hospitals or different providers. And closely tied to that is the buzzword accountability. So if, it's very hard to figure out just based on reading a chart if a patient got good care or bad care. But if you have simple measures of outcome, you can actually compare outcomes among different providers and institutions, and insurance companies or Medicare or the public can reward or punish good or bad providers or hospitals. Now, the danger is what Professor Muller calls metric fixation. And he says there's three components of that. And one is using simple metrics to avoid complex analysis and decision making. Again, it's appropriate in some circumstances, but certainly not others. Metric fixation also includes making these simple quality metrics public without educating the public about their limitations. If you imagine a 30-day mortality outcome for Jackson Memorial Hospital, it's probably going to be higher than, Doctors Hospital in Coral Gables, but we have a level 1 trauma center, and we take care of some of the most sick disaster patients in the country. If you just publicize the 30-day mortality statistic, that's misleading. Also, the third component of metric fixation is using simple quality metrics to rank and then reward or punish a very broad range of providers or institutions. And I'll show you some evidence that at the very top and the very bottom of the simple quality metric scale, it may be possible to identify the few hospitals that should be closed or the few doctors who shouldn't be practicing. It may be possible to identify a very small number of high-performing institutions, but for the vast majority in the middle, you know, if you get 2 stars versus 3 stars or 2 stars versus 4 stars from Medicare, it probably doesn't mean that there's a significant difference in performance. A couple of famous academics over the years have said pithy things about the dangers of metric fixation. Dr. Donald Campbell, who is the president of the American Psychological Association for decades, said, the more that you use these metrics for decision-making, the more subject they are to corruption, and the more likely it'll be to distort the processes that it's intended to monitor. We'll see some examples of that. And Dr. Marilyn Strathern, she was a professor of I think sociology. This is her as an Oxford professor, but she actually spent decades literally in the jungles of Papua New Guinea with literal cannibals, making her name as an academic. And she wrote pithily, when a measure becomes a target, it ceases to be a good measure. So I'm sorry for the wordy slide, but you know, I think this gives us sort of in our own experience what happens when we become fixated on these metrics and they become so important for things like doctor reputation, hospital reputation, and payment. Professor Muller says that there's 2 categories of things. One is kind of due, and again, it's the way he says things, one is kind of due to laziness. One is due to malicious intent. And you know, the things that happen when we try to find these metrics that are just due to the fact that we don't have the resources to really assess good medical care in most cases is we measure what's only easy to measure. So an example would be, you know, if we look at 90-day stroke outcomes, it's very easy to assess whether a patient is alive or dead. And if they're lost to follow-up, you can just look them up on the Social Security database. What about quality of life? Well, quality of life is hard to measure. It requires surveys and instruments. You have to contact patients after discharge. You may have to talk with their families. So most of our, for example, stroke outcome measures are very simple metrics that may not reflect really how well patients are doing. It's also very easy to measure inputs rather than outcomes. So US News and World Report, a big part of their ranking metric is the number of nurses on staff at a hospital and the number of ICU doctors who work in the hospital. Now, are the nurses taking care of patients, or are they required to do, you know, reams of paperwork, you know, during their shift? Are the doctors good, or are they, you know, are they not good? That's really hard to measure, but it's easy to say how many staff a hospital pays, you know, on their staff. You know, we're always asked to check the box in our clinic of whether we've provided smoking cessation materials to our patients. That's a very easy metric to measure. What's harder is, you know, do any of these patients actually quit smoking? You know, does their COPD get better? We don't measure that because it's very hard to measure. And standardization of data is a problem. And, you know, scientists call it lumping rather than splitting. So an example of that is 30-day all-cause mortality. And a lot of you have heard my story. When I first came to the VA, my first job was to get through a literal pile of old-fashioned paper charts on my desk. Someone in Washington had noticed that our department, our neurosurgical services department, which should have 0 to 1 death a year, had 2. So we had a 100% increase in our mortality. This led to an investigation, and the new neurosurgeon had to go through the charts. And what triggered this was we had 2 patients who died within 30 days of surgery. One came into the ER brain dead from a massive cerebellar hemorrhage and had a heroic operation, but he remained brain dead. The other patient was in the medical ICU for months in multiple organ system failure. One of our surgeons did a sural nerve biopsy to look for critical illness polyneuropathy, but a few weeks after the sural nerve biopsy, the patient died. So that was considered 2 patients who died within 30 days of their neurosurgical procedure. And that simple metric clearly was not in line with common sense. I guess things get a little juicier when you talk about gaming the system, right? Things that are done with intent. And we see this all the time. You know, what the author calls skimming the cream, right? Taking the good patients and sending disaster patients to other hospitals. You know, when I'm on call, I get these calls from other hospital ERs. They have patients with non-survivable intracerebral hemorrhages or other things that can't be helped, and they know it, but they send them to us because they don't want them to die at, you know, Baptist Hospital, for example. Lowering standards, I don't think we really see that much in our clinical practice, but, you know, we fly a lot to New Jersey to see family, and none of our flights are ever late. And the reason is that the airlines have decided that we expect 3 hours and 20 minutes of flight time to get from Fort Lauderdale to Newark. And that's ridiculous, right? It should be an hour and a half flight. But if you say it should take 3 hours and 20 minutes, your flight's never going to be late, right? So I think we see this like sometimes with things like OR turnover time predictions, but I don't think we really see it in our daily practice. There is the deliberate distortion of data. So you're not making up data, you're not hiding data, but you're just reclassifying it. So I don't know if you guys remember, a few years ago, there was a big push to put certain patients at Jackson into 23-hour observation rather than admitting to inpatient. And it turns out the reason for that is that in 2010, Medicare started cutting reimbursement rates if patients were readmitted to the hospital within 30 days after a prior admission. So if they came back to the ER, well, if they were readmitted to the hospital would take a big cut in reimbursement. But if you admitted them to 23-hour obs, it didn't count as a readmission. So that's an example of distorting data. This is a horrible one. I've only seen this once in my years of practice, but a patient who underwent a surgical procedure, not neurosurgery, it was another service, who had an intracranial disaster and was almost but not quite brain dead. And he was very, very aggressively treated and kept alive for exactly 30 days. And on day 31, the primary team decided that his case was hopeless. He wasn't going to get better, and they sent him to hospice for withdrawal of care. So keeping patients alive for exactly 30 days post-op is an example of deliberately distorting the data. Professor Muller, again, despite that smiley picture, kind of a churlish guy, refers to cheating. I've been at lectures both at UM and the VA where experts tell us to avoid certain language in operating notes and inpatient notes, like don't use words like inadvertent or puncture, or describe wounds in certain ways when you see them on morning rounds. And that's in order to avoid clerical staff going through the chart and finding evidence of complications. We've all done this, deliberately not collecting outcomes data, times where we say, look, don't get that post-op scan. We kind of don't want to know what it shows. That's cheating with regards to metric fixation. And when you allow metrics to start to control things like doctor reputations or payments to hospitals, these are some of the unintended consequences. I wanted to give you a case study of a non-neurosurgical metric and kind of the rise and fall of the metrics. So this is in many lay books and publications, central line associated bloodstream infections. So in the early 2000s, I think this was an Institute of Medicine report. There were 82,000 central line infections, and more than a third of patients with those infections died of sepsis. So smart people, this is Dr. Peter Pronovost, who is a critical care doctor at Johns Hopkins, said we need to do better. Came up with a simple protocol for putting in and maintaining central lines that we still use today with a simple outcome measure. Is there a positive blood culture, accompanied by fever or leukocytosis in a patient with a central line? Very simple outcome measure. He did a pilot project at Johns Hopkins and then published a huge multi-center study in New England Journal of Medicine and found that using this simple metric and testing a protocol, that he and his collaborators were able to bring central line infection rates from very, very high down to very, very low, almost zero. So that's a tremendous success story of using a very simple metric. But then what happened? So because in these very carefully controlled published studies, the central line associated bloodstream infection rates approached zero, the National Quality Forum, which is a very influential nonprofit organization of mainly public health doctors, had a meeting, I think this was in 2006, and they listed never events for patient care, meaning things that should never happen. And these include operating on the wrong side of the brain, operating on the wrong patient, patients being kidnapped, raped, or murdered in the hospital. And I agree, these should never, ever, ever happen. But they included central line infections as a never event. And I guess some of you guys who have been on the trauma service recently remember my patient, a homeless intravenous drug abuser who was in our hospital because of a wound infection and a brain abscess. And he had a central line in, or a PICC line, and he disappeared from the ward for about 6 hours. No one knew where he was. And when he came back, he had a high fever and gram-negative rods growing from his blood, from his central line. And we got a tox screen, which was negative, but it was also negative for opioids. And he was on round-the-clock opioids. So he clearly, I don't know, used someone else's urine or just put tap water in the bottle. So could that central line infection have been prevented? I don't know. I don't know that that's a never event. But in any case, it's now a never event. Medicare collects information from hospitals and providers about these central line infections. And starting in 2009, two things happened. The first is that there was going to be no further Medicare reimbursement for any expenses relating to a central line infection because it should never happen. And secondly, rates of central line infection, or the presence or absence of central line infections at your hospital, comprises part of the 9% of Medicare reimbursement that's tied to quality. So this quality metric, very, very useful for improving patient care, is now being used to rank and penalize hospitals and providers. So what's the end game? I don't know if you guys saw this, but a few weeks ago, we got an email from hospital leadership about hospital-acquired infections, particularly central line infections. It turns out Jackson still has a few, right, every month. And we need to take measures to not have central line infections. So we got a long email with lots of good advice, washing our hands, using the protocol, taking out central lines or Foley catheters when they're no longer needed, all good advice. But buried in there was an instruction, basically not to get cultures or to minimize our use of cultures. And I think that, that comes under this category of deliberately not collecting outcomes data. So this is the end game. You start with a metric. It's validated, it's very useful, it's tremendously beneficial for society and for medicine, but then it starts to be used in a fixated way and actually leads to, maybe, possibly not practice medicine. A little bit and talk about quality surgery. I want to talk about definitely one, I'm looking at my clock if there's time, two quality metric systems that are very important to us as neurosurgeons. The Medicare merit-based incentive payment system, that's 9% of our billing. I think next year it's 7% this year, and the US News that we just, we focus on at least once a year. I want to talk about their utility, how accurate they are, give you a case study, kind of almost similar to the central line infection one, but for a neurosurgery specific quality metric, and maybe talk about some ways of living with and maybe improving quality metrics. So for those of you who haven't been to faculty meeting for the last decade, Center for Medicare Services is part of the Health and Human Services Department. It has a huge responsibility, which is figuring out how to distribute the massive amount of money that's spent by Medicare, Medicaid, and now Affordable Care Act insurance subsidies. And for the past 13 years, the CMS has emphasized value-based payment. I think Timur mentioned this, rather than just payment based on how many surgical procedures or how many drugs we prescribe. And again, I'll kind of go over this quickly. This got a lot of momentum in 2008. The medical branch of the National Academy of Sciences had a several-day meeting. They issued a big, thick report that said we need to stop paying doctors and hospitals based on how much they do and pay them according to how well they do it. And a big part of this was introducing quality metrics and collecting big data. And at the time, there were quality databases like NSQIP. At the VA, we had VASQIP. But the idea was to make these databases much more robust and improve the provision of information from those databases to the public and to other governmental organizations. So this is a very brief history lesson. This is a slide from the cms.gov website. In 2008, there was a package of legislation passed that started the very first quality metric incentive program. If a hospital or provider was using the electronic medical record, you would get a little extra payment from Medicare. In 2010, the Affordable Care Act was passed, and among many, many other measures, this started pilot programs for tying Medicare or Medicaid reimbursement to quality metrics, but only for certain areas like dialysis patients, patients readmitted to the hospital, and patients with major complications. The big change was in 2015. MACRA, a big package of legislation that did many things, was passed by Congress. And among the things that it did was get rid of the sustainable growth rate, which is a sort of like an inflation measure, which increased payments to hospitals and providers from Medicare year by year. From now on, after 2015, payments would be linked to value, meaning cost control, and quality, meaning these quality metrics, more and more each year, ramping up from 1%. Next year, it's going to be 9%. It was also going to phase in participation. There were going to be more and more incentives and disincentives that would cause hospitals and providers to voluntarily submit their data to the Centers for Medicare Services. And finally, there was a lot of money and effort spent to make the databases more complete and robust and make them publicly available on the cms.gov website. So these merit-based incentive payment systems, what goes into those? So the first thing I'll say is it changes every year, and that may cause problems with research into whether or not these measures are actually valid. But 40% of the metric is quality, like these quality metrics we'll talk about. 25% is using the electronic health record, 20% is cost controls, and 15% is like random educational activities for patients and doctors, and there's small bonus points for some other things. I actually went on the cms.gov website and I downloaded their instructions for how these things are calculated. And I don't know if you guys can see this formula here. This is how one of the cost control scores is calculated. And as you can see, it's really, I don't think it's understandable to anyone like me who doesn't have like specialized mathematical knowledge. So the process by which these scores are calculated is a little bit opaque. But the idea is that 40% of that 9% of payment, and a big part of our reputational score on this publicly available website, is due to quality. So what are the merit-based incentive payment system quality measures? How are they chosen? Again, I had to do a bunch of research, right, to figure this out. So it's actually a process that makes sense. Every year, the alphabet soup federal agencies, NIH, CDC, FDA, Indian Health Service, a bunch of others, experts in different fields submit their ideas for what would be a good quality measure to the Health and Human Services. And most of these are based on previously published peer-reviewed data. For example, the central line infection metric, things that are really based on science. Then those measures become measures under consideration, or MUCs. Every winter, Health and Human Services published the list of possible MUCs in the Congressional Quarterly and invites public comment. And any individual or specialty organization can express their support or their criticism. And then there's a committee at Health and Human Services. I looked up who they are. They're mostly academic, people with masters of public health. They're experts in public health and statistics. They choose the measures each year that will be used for the next year. So it's actually not a bad system. Some of the quality measures we're all familiar with. We may not have realized why we were clicking these boxes, in the care system or UChart, but use of a first or second generation cephalosporin for surgery, post-op DVT prophylaxis, assessment of whether or not patients have surgical site infections, the infamous all-cause 30-day unplanned readmission. all those screenings that we click on for depression or smoking, all of those are quality measures that are very simple, that are across specialties. What about the ones that are specific for neurosurgery? I was only able to find a few going through the whole list for 2021. And I want you to look at these carefully, because some of them really do seem like they may be influenced by how good of a job we do of choosing our patients and performing our procedures and providing good postoperative care, but some of them not so much. So there are metrics based on the point scores on the visual analog scale of pain 3 months after various types of lumbar surgery. There's separate categories for decompression and fusion. Whether or not we communicate results of stereotactic needle biopsies, not craniotomies, interestingly, to patients and their referring doctors. You know, again, these are things we have control over. Good doctors discuss the results with their patients. If you, as Timur pointed out, if you choose your patients wisely, provide good care, choose the right operation, you're probably going to make their pain better, right? But what about this one? It's an outcome score, a good neurologic outcome, a modified Rankin score of 0 to 2, 90 days after endovascular stroke treatment. You know, I think that we see, you know, month after month that, you know, our endovascular surgeons can do beautiful, timely operations and completely recanalize arteries. You know, but maybe the patient came in 45 minutes too late and they're, you know, they're wrecked by a stroke. Or, you know, they develop a reperfusion hemorrhage, or they're, you know, they're elderly with comorbidities. So, you know, is this measure really a good measure of quality of care provided? I would argue that some of these measures may not be. So how are these measures collected? Where does the data come from? So in my naive state, I imagine sort of federal auditors, kind of like the IRS, coming to the hospital and like sitting on West Wing 12 and going through charts. No. So it turns out hospitals and medical groups self-report this information. So when you think about data distortion or even cheating, just keep that in mind. So hospitals collect most of the data that's used by CMS just as part of their billing process. There's clerical staff that go through the charts. They collect diagnostic codes, you know, ICD-10 codes. They collect procedure codes, you know, CPT codes. They collect disease severity and comorbidity codes. That's why Jackson always tells us, please make sure that if your patient's diabetic or hypertensive or depressed or has heart failure, make sure you put that in the chart. And then also charges. Now, you know, we talk about cost. The CMS is actually not measuring cost. They're measuring hospital charges. So whatever charge the hospital puts in a patient's file. So each patient has a file at the time of discharge. By law, the file has to be in a standardized format that's the same from state to state. Those files are sent to what's called a state inpatient database, and the state inpatient databases aggregate that data. They send it to the federal government. And there's the main one, which is the Healthcare Cost Utilization Project by CMS, but then there's a whole bunch of other databases that use the same data. Now, what's interesting is if you have enough money, or if you have the desire to do this, your hospital or your provider group can actually pay a contractor to do this data gathering and submission for you. So big hospitals and certain organizations can actually pay to have this done in a way which, you know, to be charitable, right, will make sure that you submit all the data so that it's there and that you get paid everything that your hospital or your group deserves. Now, does that mean that there may be some unfairness? A small group, a group without money, a hospital in a poor neighborhood may not be able to optimize their data? Probably. And then there's another thing. So groups and hospitals can opt in to having their patients surveyed. So they can pay to have a third-party vendor contact their patients by mail or phone and give them surveys about their subjective experience. Literally things like, was the hospital clean? Did you have good control of your pain? Did your doctors communicate with you? And then that data gets sent to the Center for Medicare Services. So that's where the data comes from. It's very different from what I imagined. And then how is this data made public? So it's made public on a website through the government, Medicare.gov. It's called Care Compare, and it's the search engine is very robust. You can search for individual, you can check on your hospital or your group of providers like University of Miami Neurosurgery or Baptist Neurosurgery, or you can search for individual providers. It's a little bit weird. Each of us individuals has like between 4 and 6 entries because we work at different places or have clinics in different locations, but you can search all these things. You can also search for providers for specific specialties in your city or in your zip code. And then you can look at their quality measures or their quality performance based on a star system of quintiles. It's like Uber. It's like 1 star to 5 stars. And 5 is the best, 1 is the worst. But for neurosurgeons, and this is true for, I checked, both our academic and private practice neurosurgeons here in Miami-Dade County, the only information is stuff that really has nothing to do, in my opinion, with neurosurgery. How good we are at screening for unhealthy body weight in clinic and providing educational materials, screening for fall risk in older patients as an outpatient, offering cancer screening, for lung cancer in clinic, and using the electronic health record. So don't worry, your patients can't look up our, 30-day mortality rates or our visual analog scale pain rates, only really stuff that has nothing to do with neurosurgery. So are these quality measures really useful? And I kind of divide this into 2 sets of questions. Do they correlate with anything meaningful? And are they susceptible to distortion or gaming? And then do they do the job that the government intends them to do? Do they really help patients make informed choices? And do they actually reward and punish doctors or hospitals based on their quality of care? So do they correlate with meaningful clinical outcomes? Well, some of them at least probably do, right? Like if we do a microdiscectomy, does the patient get better? Is the pain better? That, again, it's not completely in our control, but a lot of it is. Some of them, like how well stroke patients do after revascularization, I think that's, we have less control over that. It's unclear to me if patient surveys, which are self-selected groups of patients, really ever provide statistically reliable data. And there's certainly no published data on any correlation between patient surveys and other types of outcome measures that are more objective. PubMed, I looked up on PubMed, there are no published studies correlating these MIPS scores or outcomes with any other measures of clinical outcome. So there's no correlations, at least that have been published. And one of the reasons may be that because the quality measures or quality metrics can change every year, it's hard to do robust long-term research. Interestingly, one of the earlier quality databases, and I forget what it stands for, AHCRQ, which was folded into the current big database, was examined years ago. And there were about a dozen studies in the literature. There was a meta-analysis. I gave the citation here. So researchers actually looked at the AHCRQ data, and then they actually went into the medical charts to do a detailed chart review. And they found that these were very unreliable metrics. In other words, you couldn't tell based on the metric whether patients really did have a good or bad outcome. So there actually is some literature on some of the earlier databases that use very similar methodology that suggests that these big data databases may not be reliable at all. Are they susceptible to distortion or gaming? The answer is, I don't know, right? There's no data, there have been no scandals or reports in the press. But what do they say? What do detectives say? Does the suspect have both a motive and means to commit the crime? So there's definitely means, right? Because these data are all self-reported, and providers and hospitals can actually hire people that they pay, right, to try to optimize the data. And then, so there is the means and there is the motive. We're all aware of the rules of the game. This makes up 9% of our Medicare reimbursements each year. And also, it's our reputation on the line. Now, what about the jobs that these quality measures are supposed to do, right? Do they help patients make informed choices? So I would point out, just based on my own perusal of the cms.gov website, that the data that are available to the public have nothing to do with neurosurgical outcomes. And in addition, whatever, a group of public health people and statisticians actually looked at the numerical quality scores and then compared them with the quintile ranks 1 to 5 on the cms.gov website for these various quality measures. And what they found is that the lowest ranking group and the highest ranking group, 1 and 5, were statistically different. Numbers 2 to 4, the 3 in the middle, there was no statistically significant difference. So if a patient is looking for a 4-star provider or 4-star hospital rather than a 2-star provider or 2-star hospital, there's no statistical difference. And that information is not provided to consumers. So I would argue that all of this data is really not helping our patients make informed choices. Now, do they reward and punish hospitals or individual providers who provide better or worse care? Well, there are no published studies that correlate these scores with any other measures of quality of care. So there's no peer-reviewed research on this. The only thing that is in the peer-reviewed literature is that larger medical groups and larger hospitals have statistically higher merit-based incentive payment system scores. Now, is that because big hospitals provide better care than small hospitals, or large volume providers provide better care than small volume providers? That may very well be true. I mean, we have evidence that if you do, if you have a hospital that does 500 aneurysm surgeries a year, it's much better outcome than hospitals that do 20 aneurysm surgeries a year. It's also possible that big, well-funded hospitals and groups have the means to optimize their data that they send to the federal government. So I don't know if there's going to be time to talk about US news. I'm looking at my clock, but I hope there will be. But let me quickly run through a case study of one of these federal MIPS quality metrics in neurosurgery. So how it was created, how it was used so successfully for research and quality improvement, what happened when it was adopted by CMS, and I'll give you my own anecdote about the consequences. So quality measure OP-23 is you should have, when a patient with a suspected stroke comes to the ER, that patient should have a CAT scan or MRI report within 45 minutes. And that, that totally makes sense because, when they say time is brain, the sooner that revascularization is done, the better. So this started with research in the mid 2005, 2006, that when they looked at different factors that were associated with timely provision of intravenous TPA, they found that in retrospective studies, one of the things that was most tightly correlated was getting your CAT scan within, some studies said 25 minutes, some said 45 minutes of walking into the ER. So that was based on peer-reviewed retrospective chart review studies. So then a whole bunch of places, there were big studies, small studies. This is a graph from one of the studies done in Scotland. Stroke neurologists started doing quality improvement projects, and they said, okay, what can we do to get patients their IV TPA in a timely way? Let's do a bunch of interventions, including making sure we get a CAT scan, or not an MRI then, but a CAT scan within 25 or 45 minutes. And what they found in prospective, peer-reviewed, quality control research was that when they made the rule that you had to get a scan within 45 minutes, patients got their TPA quicker and clinical outcomes improved. So this was great. And there's a whole bunch of citations in the literature about this. Okay, so now it's standard care, right? Patients come in, we call a stroke alert, right? And we get them their scans very quickly. So Center for Medicare Services adopted this as a quality measure. Okay, so, both for quality reporting and also for provision of payment. So it's now on the books, right? And this is one of the reasons why when a stroke alert is called, regardless of how ill or not ill the patient is, the CAT scanner is cleared. No one else can get a CAT scan until the stroke patient gets their CT angiogram, and CT perfusion, right? It's kind of a long study. So I was on trauma call, this was about 6 weeks ago, and in the course of a week, I saw 2 patients, trauma patients, where we had trouble getting scans because of stroke alert. One patient was someone who I don't think his outcome would have been any different, but we were called about an hour and a half after he came to the ER. He came in through trauma recess. He was an elderly man struck by a car. He came in with no motor responses and dilated fixed pupils. but he didn't get a scan for more than an hour. And the reason was there was a stroke patient on the table, and apparently the ER CAT scanner was down, so they had to send the stroke patient to the trauma CAT scanner or vice versa. And in the end, he had a huge intracranial hemorrhage with brainstem hemorrhage, Duray's hemorrhages. I don't think, even if we had known the CT results sooner, I don't think the outcome would have been any different. But this was a delay, right? There was a second patient who, fortunately, I was there for. She's a young woman who shot herself in the forehead. She was awake and talking. We made arrangements to immediately bring her back to surgery for debridement and closure of the wound. And she kind of stopped talking. She deteriorated neurologically as we were getting ready to roll back. So I said, let's get another scan, just make sure she doesn't now have a big hematoma that we need to decompress. And we were told, no, we can't get a CT for 45 minutes because there's a patient on the table, a stroke alert patient who needs a CT, CTA, CT perfusion. So anyway, I walk over to the CAT scanner to find out what's going on. And I see the patient is an elderly woman. She's wide awake. She's talking with the neurology stroke fellow. She's having a conversation. She's gesturing with both of her arms. And I said, you know, we have this like gunshot wound patient who's deteriorating. We need to get this scan. So in the end, we had a common sense solution. The stroke patient got her non-contrast CT very quickly. We put our patient on the table. We got a CT that showed no new findings, got her off the table, and then the stroke patient got the rest of her study. So everyone was happy. But, you know, I think this is an example of a quality measure that then becomes, what did Professor Muller say? It becomes tyrannical, right? We are hijacking common sense, right? Because of a quality measure. So how can we live with these federally mandated quality metrics? This is not a negative talk. I think, you know, the first thing is acceptance. They're here to stay. We're not going to change that. Please, you know, I now understand, you know, so many of the reasons why, you know, Jackson, you know, and get on top of us to document things in the chart. You know, we really need to prevent loss of payment to our, you know, think of Jackson, you know, our public safety net hospital. That's so important, not to mention and not to mention our own department. I would tell my colleagues, please don't worry. Meaningful neurosurgical outcome measures are not yet being provided to the public by the federal government. We should respect and recognize how useful these simple quality metrics are for research and quality improvement outside the setting of determining our reputations or how much money we get paid. And, you know, I think things like NeuroPoint, which is sort of data collection by neurosurgeons for neurosurgeons, facilitates research in a very powerful way. And, you know, all the papers that we see published from research databases like the National Inpatient Sample show how powerful this big data using simple metrics can be for clinical research. And I would also say, as long as we use common sense and clinical judgment, I think we're going to be okay. It's 8:55. I had a bunch of slides on the US News and World Report rankings. If anyone's interested, I can send them to you, but I think I better stop here. And thank you very much for listening.